So I've actually been accused of not really liking surgery, and because I don't do so much surgical content on my channel. So I actually looked at the different playlists and actually realized that surgery is actually lagging behind. So I decided to put together this video on ulcers. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazebu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at ulcers. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. I did a video on wound and wound healing, so if you didn't see that video, I will leave it tagged right here as well as at the end of the video that you can actually go out and watch after this particular video, because remember that an ulcer is a type of wound. So all ulcers are wounds, but not all wounds are ulcers. So what exactly is an ulcer? Remember, this is just simply a break in the continuity of a covering epithelium that's going to be associated with necrosis. So it could be a break in the skin, it could be a break in the mucous membrane. If it's associated with molecular or microscopic death of tissue, we refer to that as an ulcer. Remember, all ulcers are types of wounds, but not all wounds are types of ulcers. The ulcer has different parts. It has the margin, which is what's going to be demarcating the ulcer. It has the edge, which joins the margin to the flow. It has the flow, which is what you see on the ulcer, and it has the base. You can't see the base, but you can feel the base. The base is what you feel on the ulcer. So the margin can either be regular or it could be irregular. It could be round or it could be oval. A big disclaimer, there will be some graphical images in this particular lecture. Then the edge, like I said, is what's going to be connecting the flow to the margin. There are different types of edges that are there, and the edge of an ulcer can actually give you a hint on the type of ulcer you'd expect to see. So it can give you a hint on the nature of the lesion that is underlying. What are these different edges that are there? So the first one that I want you to know is known as a sloping edge or a shelving edge. This is the most commonly seen in ulcers that are about to heal, and of course, you may get these features of granulation tissue as is depicted in this image over here. So the edges are sort of slanting. You have the inner part which is appearing red, as you can see in this particular image, and it has features of healthy granulation tissue, which I will talk about in this particular lecture. The outer aspect could be white, as we see in this area here. It could be white because of this fibrous tissue, and the middle part can sometimes be blue because of the epithelial proliferation. So that's the first type of edge. You could have a sloping edge or a shelving edge. The next type of edge is known as an undermined edge, which is seen in TB ulcers. It's also seen in decubitus ulcers, the pressure sores. So because the disease process is actually extending much deeper into the subcutaneous tissue, lower than the skin, it will appear as if it's proliferating. The skin is going to be proliferating rather inwards, and it's going to be appearing quite deep but with a very small opening. As you can see, with this ulcer here, we have the ulcer here, but you can see that it's almost even extending in the peripheries. There's a lot of swelling that is going on with a small opening. So this is often seen with decubitus ulcers. It's often seen with tuberculous ulcers. They tend to be quite deep. Then you may have a punched out edge, which I didn't add a picture of, but we see this in syphilitic ulcers, the gummatous ulcers. You also see it in some trophic ulcers or the pressure or decubitus ulcers. It's often due to endotoritis. Here the edge is going to be sharp. It's known as a punched out ulcer. You may sometimes have an elevated or everted, or sometimes it's referred to as a rolled out, because the skin is proliferating and it's spilling over. So this is often seen in carcinomatous ulcers like a basal cell or even a squamous cell carcinoma of the skin, and you have this proliferation. As you can see, the edges of this ulcer are proliferating, and this is a malignant ulcer. You may sometimes have a raised and a beaded type of ulcer, which is also referred to as pearly white. As you can see, the edge is going to be, sorry, I don't know why I keep doing that. The edge is going to be raised, and you're going to be seeing these, like it's beads around this ulcer. This is a rodent ulcer, and it's going to be because of proliferating active cells. It's also going to be seen in basal cell carcinomas. As you can see, to some extent, it's also pigmented. Then the flow is what you're going to be seeing so you don't touch the floor, you can see what's on the floor. You can see that there are different discharges that are there. There could be slough, there could be granulation tissue. There are different things that you can see on the floor. So in terms of the base, this is where the ulcer is going to be resting on. Remember, you don't see the base, you can feel the base. So it can either be sitting on bone or hard tissue, it could be sitting on soft tissue. And remember that this is a type of wound. There is some inflammation that can sometimes take place. And sometimes this inflammation could affect the surrounding tissues, and it can cause this ulcer to become fixed and quite tender. It may become painful. In some cases, the tissue actually being fixed and the surrounding tissue being hard, induration is like this hardness that you feel, could sometimes be indicative of a neoplastic infiltration, a malignancy. Like I always tell people, cancers are not always painful. The cancers may be painful if they are going to be infiltrating into a certain structure like a nerve, or they are going to be compressing on a nerve, or in particular locations. But generally, you get this type of ulcers that have this induration around them and they don't even feel tender. Then you refer to these as, or you should have some suspicion that there is some neoplastic infiltration. So here are the different types of edges: sloping, which is indicative of a venous ulcer; punched out, which is a neuropathic or even syphilitic ulcer; undermined or undetermined, decubitus or even sometimes TB; rolling edge, you have basal cell carcinoma; everted, you have the squamous cell carcinoma. Remember, you have the edge, which are the different types there. You have the margin, which is the surrounding of the ulcer. You have the floor, which is what you're going to be seeing. You could see granulation tissue. You have the base where it's going to be sitting on. It could be sitting on soft tissue like muscles. It could be sitting on bone. Then, of course, some of these processes are going to involve the regional lymph nodes actually being swollen. So induration is just simply the sign that you're going to elicit when you palpate. It's this type of hardness in diseased tissue. In the well-differentiated carcinomas, it's actually quite obvious, and you can better feel it in the squamous cell carcinomas. It's because of this long-standing ulcer that you're having that could sometimes even have this underlying fibrosis. You could see this and you could feel induration. It's absent or even less in the poorly differentiated carcinomas, and the malignant melanomas are not going to give you much of the induration, because if you look at some of these pathologies, if you look at how these cancers are spreading, some of them spread in a horizontal manner, some of them spread in a vertical manner, going deeper and deeper into the structures. So less indurated carcinomas actually tend to be much more aggressive, because remember that the malignant melanomas are quite aggressive type of cancers. And the specific types of induration are observed in venous disease, even in chronic deep venous thrombosis. We may sometimes have a special type of induration that is known as Brownie induration, which we often see with abscesses. And the induration is felt at the edge, the base, and surrounding the area of the ulcer. Remember that induration at the surrounding areas is going to signify that there is some extension of the disease. And the outermost part of induration is actually taken as the point where the clearance of the wide excision should be planned if you're trying to remove that ulcer or excise that ulcer. There is a classification system that I just want to touch a bit. It's in relation to diabetic foot. It's known, or a diabetic ulcer, it's known as a Wagner's classification. So grade 0 if you have preulcerative lesions or a healed ulcer. Grade 1 if it's superficial ulcer. Grade 2 if the ulcer is extending to the subcutaneous tissue and it's exposing the soft tissue or the bone. Grade 3 if there's an abscess that's forming or an underlying osteomyelitis. Grade 4 if there's gangrene of part of the tissues or even the limb. Then grade 5 if there's gangrene of the entire one area or the entire foot. Ulcers could be classified using two systems. You could have a clinical classification or a pathological classification. Clinically, they could be based on the location, whether this is an arterial ulcer, which tend to be on the lateral aspect, for example, of the foot, and the venous ulcers, which tend to be occurring on pressure sites, for example, the dorsum or the medial aspect of the foot. You could classify them based on what you're seeing on the floor of the ulcer, whether this is according to the granulation, whether it's healthy granulation or unhealthy granulation. It could be based on the discharge that you see, whether it's serous, which could be seen in granulation ulcer tissue, or it could be blood, which is often indicative of malignant, or even purulent, which means it could be there's an infection or it's spreading ulcer. It could be based on the edges, which I've talked of the different edges: sloping, indicative of healing ulcers; punched out, which are indicative of syphilis; and trophic ulcers or pressure ulcers. Undermined, which are indicative of TB, rolled or elevated, which is indicative of malignancies, and then raised and beaded, which is also indicative of malignancies, or based on what the surrounding area looks like. If it's thick and pigmented, it's usually a varicose ulcer. If it's thick and dark, usually arterial ulcers. So that's the clinical classification, just basically the characteristics of the ulcer. Then it could be pathological. You have those that are specific ulcers, meaning that there's an associated cause that you can link to this. For example, tuberculous ulcers, syphilitic ulcers, actinomycosis, Melanese ulcers. You could have those that are malignant. For example, the carcinomatous ulcers, that's the Majolin's ulcers. You may have the rodent ulcers, even melanotic ulcers. Then you have non-specific things that are not associated with a specific cause. They may be caused by various things. Traumatic ulcers, which are very common, could be due to mechanical forces, chemical, even physical. Arterial ulcers, which could be caused by atherosclerosis or the vasculitis. Venous ulcers, which are gravitational ulcers or post-phlebitic ulcers. You could have trophic ulcers. Infective ulcers, which are pyogenic. Trophic ulcers, like for example, Vincent's ulcer. You could have ulcers due to chill bites or frostbite. You could have ulcers which are due to hypertension. You could have diabetic ulcers that could be caused by many things. Ulcers that are seen in patients with leukemia, polycythemia, jaundice, collagen diseases, lymphedema. And of course, it could be those that use these lightening creams. They could sometimes develop ulcers. And these ones can sometimes even require excision and skin grafting. Now, I said I'll talk a little bit about granulation tissue. Remember that when an ulcer is healing, it must have healthy granulation tissue if it's going to be healing adequately. So remember, number one, the edge is supposed to be sloping. It will bleed when you touch it, and it has this serous discharge. There are these characteristics of healthy granulation tissue that we often see. It's pink. There's punctate hemorrhage. It bleeds when you touch it. It pulsates. It's painless, and it has the characteristic appearance of a pinhead granulation. You see these 5 things, then you know that this is healthy granulation tissue, and the skin graft is going to take up very well if you have a healthy granulation tissue, such that if you get any swabs from this area, you should culture less than 10 to the power 5 grams of streptococci from that area if you were to put a skin graft and for this skin graft to actually hold. Then unhealthy granulation tissue often is going to appear pale. You may have this purulent discharge. There may be slough that is covering the wound. It may be inflamed. It may be edematous. It may be spreading. And then, of course, you may have flat granulation, which is sometimes even pale, unhealthy, which is seen in chronic non-healing ulcers, or what we call callus ulcers. Now, how do we assess a wound? We want to take a good history. We also want to do a proper physical examination. On our history, we're interested on the mode of onset, the duration, the pain, its onset, the progress and the severity, any discharge that is coming out from the ulcer, how many ulcers does this patient have, any history that may be suggestive of an underlying associated disease or any treatment in the past. Then this can help you actually determine the cause of the ulcer. You should find out the cause, whether it's diabetes, whether it's a venous ulcer, whether it's an arterial ulcer, or if it's an infective ulcer. When it comes to examination of the ulcer, just like any other examination, you want to, of course, greet your patient, you want to gain consent, you want to introduce yourself and explain what you're about to do. And just like any other examination, you're going to start off with your general examination, which I won't dive into details in this particular lecture, and then you come now to your local examination. Unless if it's specified that they have told you to examine the ulcer and go straight into the examination of the ulcer, then you can examine the ulcer. And remember, every examination starts off from the foot end of the bed, then you move on to the right side of the bed. So from the foot end of the bed, on inspection, you want to see the site of the ulcer. Remember, if arterial ulcers tend to be in the digits, and if they're on the foot, they tend to be on the lateral aspect. Is it venous? This tends to be on the medial aspect, the malleoli, the pressure sites. Is it trophic? They tend to be on the heels, the pressure points. You'll comment on the size of the ulcer, the shape of the ulcer, the perceived depth of the ulcer, the number, if there's one or there are many, the margin, whether it's appearing regular, whether it's irregular, whether it's well-defined, whether it's poorly defined, and of course the edge. You can talk about this. Remember, later on you're going to palpate and feel for the induration. So if it's indurated, it may be suggestive of a squamous cell carcinoma or a chronic ulcer. You should also comment on the flow. Remember, the flow is what you see. It's not what you're touching. First, it's inspection before you touch. It's going to be resting on a base, and the base is what you touch. So how does the flow look like? Is it red in color? Maybe this could be a healing ulcer. Is there a slough? Is it pale? Is there a purulent discharge? Maybe it's a non-healing ulcer or a tubercular ulcer. Is there like wash leather like slough, which is often indicative of a syphilitic ulcer? Is there any proliferative or nodular flow that you can see, which is indicative of a squamous cell? Is it pigmented, which could be pointing you towards melanomas, which could be pointing you towards pigmented basal carcinoma? What's the discharge that is there? Is it serous in the case of healing ulcers? Is it purulent, yellowish type of discharge? If it's yellowish or creamy, it could be staphylococci. If it's bloody and opalescent, it could be streptococci. If it's greenish in color because of the pseudocyanin, it could be due to Pseudomonas. Is there any blood? Maybe this is a malignant ulcer, or maybe it's healing from healthy granulation tissue. Is it seropurulent? Is it serosanguinous, serous mixed with blood? Or is it serous with these sulfur granules in the case of actinomycosis? You also inspect the surrounding area for any inflammation, any edema, any eczema, any scarring, or any pigmentation, and make sure to inspect the entire limb. Then you come to your palpation and you touch the ulcer. You feel if it's tender, you touch the edges, the base, and the surrounding area to feel for any tenderness, feel for any warmth, feel the edge for any induration, and palpate the base to see if it's fixed and if it's indurated. If it's fixed, think maybe this could be a malignancy. If it's not indurated, maybe it's a non-malignant cause of the ulcer. You could actually estimate the depth of the ulcer. Remember, trophic ulcers tend to be quite deep, and they can actually even reach the bone. And then you check if there's any bleeding when you're touching the ulcer, palpate the deeper structures and how they relate to the ulcer. Palpate the surrounding skin, for example, the tibia, the calcaneum, and other related bony prominences. Examine the adjacent joint if there's mobility that is there, if there's tenderness in that joint, and also examine the regional lymph nodes to that area. If they are tender, it could be that this is an acute infection. If they're mobile and they're consistently hard, maybe this could be a carcinoma that has spread to the lymph nodes. If they are firm, soft, and non-tender, maybe it's an inflammatory process. If they're fixed, you're thinking malignancy. If they are ulcerated or even fungating from that area, you're thinking maybe this could be a malignancy. If there's a sinus that has formed, this is usually sometimes non-specific, could be pointing towards TB or even sometimes carcinomas. Palpate for the peripheral pulses and comment on the peripheral pulses. You also want to auscultate the peripheral pulses for any bruits that could indicate some form of obstruction. Then you could go on to perform specific systemic examination, for example, examining for varicose veins when they stand up, checking for the abdomen for any splenomegaly in the case of sickle cell disease or any hepatomegaly. You could examine the spine for any gibbous or any paraspinal spasms or movements, and the neurologic system for the sensation and the muscle power. Investigations that we want to order, we want to do a study of the discharge. So you want to swab the discharge. Make sure you swab from at least 2 areas of the center and even 2 different areas of the margin. Send this for culture, microscopy, and sensitivity. Also send this for AFP studies and cytology. And remember, for a skin graft to hold, less than 10 to the power 5 of those organisms. And then you could sometimes get a biopsy of the edge. So you can biopsy the edge, and you can see the different cells that are present there, those cells that are multiplying. Obviously, you're going to want to take 2 biopsies, one from the center, one from the edge. So the biopsy that's often taken from the center may not be so adequate because sometimes there's some necrosis there, the tissues that are dying there. You also want to do a fine needle aspiration and cytology for the lymph nodes that could help you point towards malignancies that may have spread to these particular lymph nodes. You want to get an x-ray of the part, which may point you towards periosteitis and even osteomyelitis. Get a chest x-ray if you're suspecting maybe this is a tuberculous ulcer. You may get those characteristic features that we see in TB. Get a full blood count. Remember, ulcers are not going to granulate if your HB is low. If your HB is less than 10 and your albumin is less than 3 grams, then your ulcers are not really going to heal so well. So make sure that this person is optimized in terms of the HB, optimized in terms of the albumin. How do we manage these ulcers? So the principles of management include the following things. You want to investigate and treat the underlying cause. You want to correct any deficiencies like anemia, protein, or even vitamin deficiencies, because remember, these factors are going to affect wound healing. You want to transfuse them with blood if they need so. Control the pain, give them analgesics. Control any infections by antibiotics. Make sure you rest that part, and these antibiotics must be targeted. So make sure that you do a culture, microscopy, and sensitivity. But in the meanwhile, The results for the culture microscopy sensitivity should not delay you starting with antibiotics. You should care for the ulcer by debriding it and cleaning the ulcer each and every single day. And in some ulcers, you may actually dress them up. And there are different techniques, both conventional and non-conventional things. If you really want to learn the conventional things, just see me one of these fine days in person. I will teach you how to handle these ulcers very well. So in terms of ulcer cleaning, remember we often do it with povidone, iodine, and normal saline, which is usually ideal. There are some ulcers that I've seen being cleaned with antibiotics. There are some ulcers that I've seen being cleaned with hydrogen peroxide. So you should make sure that you consult before you use those caustic agents. So this should be done daily. Sometimes you can do it twice daily. Sometimes you can do it 3 times a day, sometimes 4 times a day, depending on the severity. Then in terms of debridement, it's just simply removal of the devitalized and the dead tissue. For the small ulcers, you want to actually remove them on the ward. I had a consultant that used to say, clean it until it bleeds. And that's how you know that you're making some progress. But of course, you don't want to bleed too much because this patient will keep losing blood. Then for the larger ulcers, we often tend to debride them in theater under general anesthesia. So remove all the dead tissue or the devitalized or the necrotic tissue, everything is removed. Then the slough should be separated adequately before debridement, and often the devitalized tissue separates on its own by autolysis. Sometimes we can use some enzymes like collagenase that can be used for debridement. Sometimes we could use hydrotherapy and dressings for mechanical type of debridement. And remember that debridement could be done surgically, where you actually cut out the dead tissue. It could be mechanical, it could be autolytic, sometimes it could be enzymatic. I've even seen maggots sometimes being used on certain wounds. Where they apply maggots, the maggots are going to be eating away at the dead tissue. Then the dressing of the ulcer is actually aimed to keep it moist, to keep the surrounding skin dry, to reduce the pain, to soothe the tissue and to protect the wound, and as well as absorb any discharge. There are different types of ulcer dressings that have advantages and disadvantages, and not all ulcers are actually going to be covered up. Some of them may actually leave them open. So cotton dressing, it's quite cheap, but it's traumatic every single time you're removing. A good hint is that once you cover it up with some cotton, when you remove the ulcer, you can sometimes pour some normal saline to it, and it can actually help the cotton wool come off. But if you want to be quite brutal, you can actually rip it out very quickly. That actually also helps remove some of the dead tissue when you're removing the cotton dressing. Then you may have some paraffin dressing, you may have polyurethane dressing, which is used in clean wounds. You may sometimes have biological dressings like alginate, which are used in those that have heavy exudates, type 1 collagen dressings that I've seen being advertised at the hospital. I've never used them, but I'm sure they do work some wonders. These ones, they cause hemostasis, they cause proliferation of the fibroblast, and even increase the blood supply. You may sometimes have foam dressing, which are highly absorbent, and they're going to be decreasing wound maceration and reducing the frequency of the dressing. They are hydrophilic forms. Then you may have hydrocolloid dressing, which can help in separating the slough and autolysis of the dead tissue. You may sometimes have transparent film dressing, which are waterproof and they'll permit oxygen and water vapor across and prevent contamination. You may sometimes have some hydrogel dressings which are used for clean wounds. Then remember that chronic ulcers could sometimes be seen in our practice. These are often going to be seen in the skin. It could be due to recurrent infections that are being undertreated, trauma, it could be absence of rest, poor blood supply, hypoxia, edema of the area, you could have loss of sensation, malignancies, and some specific causes like TB is one of the things that could cause chronic ulcers, fibrosis, periosteotitis, osteomyelitis of the underlying bones. Make sure when you're dealing with a chronic ulcer, you should see the full history of what has been happening to this patient and actually try to determine what is the underlying cause, because as long as you haven't addressed that underlying cause, that ulcer will still remain there. I really hope you enjoyed this video on ulcers. If you did, consider subscribing to the channel, hit the bell notification icon to be receiving notifications on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.